A 74-year-old woman with heart failure, bilateral severe osteoarthritis, dyspepsia, who had a fall in the bathroom, has been on ibuprofen for 400 milligram BD, omeprazole 40 milligram daily, spironolactone 50 milligram, captopril 10 milligram daily, amiloride HCT. She presents to the hospital due to severe pain. Radiograph is normal. Blood pressure is 115/70. Creatinine is 2.3 milligram per DL. EGFR is 20 mils per 1.73 meters square. PCV is 28%. Potassium is 5.5 millimole per liter. She was prescribed IV morphine 20 milligrams 6 hourly and was discharged home on oral morphine 20 milligrams 6 hourly alongside her regular medications. She presented again 2 days later with altered consciousness, vomiting, abdominal distension, and constricted pupils. Okay, so the questions are, what is the diagnosis for the second presentation? 2, list 4 clinical features to support the diagnosis. 3, what are indications and predisposing factors for the first presentation? 4, how will you manage these patients? 5, how do you prevent this from reoccurring? 6, what are reasons for the second presentation? 7, criticize the medications the patient is on. Okay, so 1, what is the diagnosis for the second presentation? The answer is opioid toxicity and narcotic ball syndrome secondary to opioid overdose. Okay, 2, okay, so list 4 clinical features to support the diagnosis. So there's CNS depression, that's the altered consciousness. There's vomiting, there's abdominal distension, and then she had constricted pupils. So question 3, what are indications and predisposing factors for the first presentation? So the indications are a history of fall, severe pain, and bilateral osteoarthritis. And then the predisposing factors are polypharmacy, high dose diuretics, chronic NSAID use, background heart failure, and her age is elderly. Then 4, how will you manage this patient? Okay, so the diagnosis, suspected opioid toxicity with narcotic bowel syndrome secondary to opioid toxicity. So the initial assessment is an emergency. So you do your ABC of resuscitation. Can obtain further history from the patient. Can do a quick examination to confirm the findings already given and to look out for other signs. So you administer IV naloxone 0.4 milligram to 1 milligram. And then reassess for improvement in her Glasgow Coma scale and resolution of respiratory insufficiency. So continue. Repeat the IV naloxone every 2 to 3 minutes to a maximum of 10 milligram until patient regains full consciousness, and then you can discontinue the naloxone. If there's no intravenous access, it can be given via intramuscular or subcutaneous, intranasal, or endotracheal or intraosseous routes. If the patient is still unresponsive after the maximum dose of naloxone, that's 10 milligram, you can use buprenorphine. So when the patient regains consciousness, you can admit to a high dependency unit for observation for 12 to 24 hours. So for inpatient care, you can take samples for full blood counts, molecular urea and creatinine, treat any infections if there are features of infections. The patient may require hemodialysis with declining renal function. Medications should be reviewed and adjusted. You may give diuretics, discontinue the NSAIDs and the morphine, and then manage the pain with alternatives. Check for prescription drug monitoring program data for prescription for opioids and other controlled medications patients have received from other clinicians to determine whether a patient is receiving opioid dosages or combinations. Sorry for that. Opioids combined with, that's for example, opioids combined with benzodiazepines. that put the patient at high risk for overdose. Then you can incorporate the American Geriatric Society BS criteria for potentially inappropriate medication use in older adults for prescribing medications for the elderly. Okay, so what are the reasons for the second presentation? Patient developed vomiting, abdominal distension, altered consciousness, all due to opioid overdose and worsened by renal impairments and polypharmacy. So besides the medications the patient is on, so she was on ibuprofen, 400 milligram BD, which is an NSAID. It worsens renal function, increases sodium and water retention and then worsens the heart failure. The omeprazole 40 milligram daily, it increases the incidence of pneumonia and worsens osteoporosis and dementia. And then this spironolactone, 50 milligram, is a high dose potassium sparing diuretics. You notice her potassium level was 5.5. Then the captopril, ACE inhibitor, it worsens the hyperkalemia. Then the amiloride HCT, the thiazide, and they're also potassium sparing. IV morphine 20 milligrams 6 hourly, then oral morphine 20 milligrams 6 hourly. High dose morphine, she should have received like 25% of this dose. So for management of opioid toxicities, opioid overdose occurs when a person has excessive unopposed stimulation of the opioid pathway. This can lead to decreased respiratory effort and possibly death. The frequency of opioid overdose is rapidly increasing. Drug overdose is the leading cause of accidental deaths in the United States, with opioids being the most common drug. Okay. Can I go on the introduction? An opiate is derived from the opium poppy plant, while opioids are substances that act on the opioid receptors. Opioids work via the endogenous opioid system by acting as a potent agonist to the mu receptor. This results in a complex cascade of intracellular signals, resulting in dopamine release, blockade of pain signals, and a resulting sensation of euphoria. Opioid receptors are located in the brain, spinal cord, and guts. In overdose, there is an excessive effect on the portion of the brain regulating respiratory rates, resulting in respiratory depression and eventually death. The typical symptoms seen in overdose are pinpoint pupils, respiratory depression, decreased level of consciousness. This is known as the opioid overdose triad. That's pinpoint pupils, respiratory depression, and decreased level of consciousness. The opioids may be agonist, partial agonist, or agonist antagonist of opioid receptors. The currently available opiates lower the perception of pain and in some cases decrease the pain stimulus. When these receptors are stimulated, it results in suppression of the pain sensation. However, not all opiate receptors have the same analgesic potency when stimulated. Opioids reduce pain perception by inhibition of synaptic neurotransmission and binding of opioid receptors in the central and peripheral nervous system. The main opioid receptors that mediate effects of opioids are mu receptors. They mediate analgesia, euphoria, sedation, respiratory depression, gastrointestinal dysmotility, and physical dependence. Mu receptors cause a medullary diminished response to hypercarbia and also a decrease in the respiratory response to hypoxia, resulting in a decreased stimulus to breathe and development of apnea. The kappa receptors mediate analgesia, diuresis, meiosis, and dysphoria. Delta receptors mediate analgesia, inhibition of dopamine release, and cough suppression. So for the etiology, causes complications of substance abuse, unintentional overdose, intentional overdose, and then therapeutic drug error. So risk of opioid overdose increases in the following: those that take escalating doses, return to use after cessation, those with severe medical and psychiatric conditions such as depression, HIV, and lung and liver disease, those that combine opioids and sedative medications, male gender, younger age, 20 to 40 years, and then white non-Hispanic race. The clinical features universally may be lethargic or have a depressed level of consciousness, respiratory depression, and meiosis. The skin, you may see needle track marks, patch marks on the body from the use of fentanyl, itching, flushed skin, and urticaria. Pulmonary features, respiratory distress and hypoxia, shallow breathing, hypopnea, and bradypnea, with respiratory rates of 4 to 6 cycles per minute. There could be bronchoconstriction, which presents as dyspnea, wheezing, and fluffy sputum. Cardiovascular system, patient could present with hypotension and arrhythmias. The GIT, patient could present with nausea, vomiting. Psychiatric features are anxiety, agitation, depression, dysphoria, hallucinations, nightmares, paranoia, and then neurological symptoms. Generalized seizures can occur, especially in young children and adults. It's where those who take zifin or redeem the present with meiosis and dresses. So for treatment, at the same time, and intervene appropriately. Naloxone should be given if available after securing the airway. At the emergency department, do your ABCDE protocol. Initial care. Naloxone should be administered as soon as possible. You can give activated charcoal if the patient is conscious or presenting within 1 hour of ingestion of the opioid. Then do bowel irrigation for those that ingested drug packs containing opiates. Then other measures, you can give buprenorphine, then counseling and rehabilitation. The differentials include clonidine toxicity, cyanide toxicity, diabetic ketoacidosis, ethylene glycol toxicity, gamma hydroxybutyrate toxicity, hypercalcemia, hypernatremia, hypothermia, meningitis, and neuroleptic agent toxicity. So the complications include acute lung injury, infections such as cellulitis, endocarditis, necrotizing fasciitis, narcotic bowel syndrome, rhabdomyolysis causing renal impairment, and then withdrawal reaction. Opioid stewardship. Determining when to initiate or continue opioids for chronic pain. 1, non-pharmacological therapy and non-opioid pharmacologic therapy are preferred for chronic pain. And then 2, before starting opioid therapy for chronic pain, clinicians should establish treatment goals with all patients, including realistic goals for pain and function, and should consider how therapy will be discontinued if benefits do not outweigh risk. And then before starting and periodically during opioid therapy, clinicians should discuss with patients known risk and realistic benefits of opioid therapy, as well as patient and clinician responsibilities for managing therapy. Opioid selection, dosage, duration, follow-up, and discontinuation. So when starting opioid therapy for chronic pain, clinicians should prescribe immediate release opioids instead of extended release and long-acting opioids. When opioids are started, clinicians should prescribe the lowest effective dosage. Should also use caution when prescribing opioids at any dosage, and should carefully reassess evidence of individual benefits and risk when increasing dosage to like morphine 50 milligram equivalents per day, and should avoid increasing dosage to more than 90 morphine milligram equivalents per day, or carefully justify a decision to titrate dosage to more than 90 morphine milligram equivalents per day. So long-term opioid use often begins with treatment of acute pain. When opioids are used for acute pain, clinicians should prescribe the lowest effective dose of immediate release opioids and should prescribe no greater quantity than needed for the expected duration of pain severe enough to require opioids. 3 or fewer days will often be sufficient. More than 7 days will rarely be needed. Clinicians should evaluate benefits and harms with patients within 1 to 4 weeks of starting opioid therapy for chronic pain or of dose escalation. Clinicians should evaluate benefits and harm of continued therapy with patients every 3 months or more frequently. If benefits do not outweigh harm of continued opioid therapy, clinicians should optimize other therapies and work with patients to taper opioids to lower dosages or to taper and discontinue opioids. So before starting and periodically, during continuation of opioid therapy, clinicians should evaluate risk factors for opioid-related harm. Should incorporate these into their management plan strategies to mitigate risk, including considering offering naloxone when factors that increase risk for opioid overdose, such as history of overdose, history of substance use disorder, higher opioid dosages, that's more than 50 morphine equivalent per day, or concurrent benzodiazepine use are present. Clinicians should review the patient's history of controlled substance prescriptions using state prescription drug monitoring program data to determine whether the patient is receiving opioid dosages or dangerous combinations that put him or her at high risk for overdose. Clinicians should review the prescription drug monitoring program data when starting opioid therapy for chronic pain and periodically during opioid therapy for chronic pain, ranging from every time a prescription is written to every 3 months. When prescribing opioids for chronic pain, clinicians should use urine drug testing before starting opioid therapy and consider urine drug testing at least annually to test for use of medications, as well as other controlled prescription drugs and illicit drugs. Clinicians should avoid prescribing opioid pain medication and benzodiazepines concurrently whenever possible. Clinicians should offer or arrange evidence-based treatment, that's treatment with buprenorphine or methadone in combination with behavioral therapies for patients with opioid use overdose. So when potentially harmful behaviors are identified, e.g. high volume use of opioids, taking opioids in combination with alcohol, benzodiazepines, or other respiratory depressants, using illicit opioids where contents of substance cannot be confirmed. It's important to offer education that can reduce that individual's risk for overdose. Providing basic risk reduction messaging, overdose prevention, education, and naloxone prescription can be life-saving interventions. Risk reduction messaging from a prescriber may include information about which other medication a patient is taking that are respiratory depressants, example, benzodiazepines, anti-seizure medications, and many psychiatric medications are respiratory depressants. So care of the elderly. The elderly population aged 65 years and older is increasing throughout the world. There's increased hospitalization from 2003 to 2009 in the United States. So due to multiple comorbidities and frailty, they are at increased risk of adverse outcomes with each clinical insult. They can present with atypical presentation of illness. The elderly population varies in cognitive, physical, and social functioning, and thus requires different levels of care based on individual needs and functional status. Geriatric assessment involves a coordinated approach for the physical, functional, and psychosocial assessment of the elderly to formulate an integrated plan of care. So issues of concern in geriatric assessment can be broadly divided into the following four classes. 1, functional status. 2, physical health vision impairment, that's hearing loss, nutrition status. 4, prevention, urinary incontinence, osteoporosis and arthritis. Polypharmacy and medication reconciliation is the third class, and then the fourth, cognitive assessment, dementia, sleep and insomnia, mood disorder. Okay, so that's the end.
Yeah, thank you very much, Dr. Ekele, for presenting on behalf of the class. So if we have any contributions or any questions, we can discuss within ourselves. Or yeah, basically maybe contributions. So if you know the question you're asking, you have the answer, just put it forth as a contribution. And if you don't know, we'll try and attempt to answer you. I don't know if Dr. Henry still has joined us, because we want to finish this series.
Good morning.
Before we go to
I'm in.
Yeah. Okay, you are in. Okay,
Yes,
Dr. Ekele, can you unshare your slide so that he can share his? Okay. Any contributions? Any questions? Okay, Dr. Shamsuddin, can go ahead.
Okay. Thank you, sir. Thank you, our teachers and colleagues. Good morning, all. Oh, my comment is to do with the medications review. Medication review is a standard care in management of older adults. So in this patient, for example, patient is ACE inhibitor, is also on an NSAID. Both of them can actually worsen the kidney function. So one of the modifications that should be made is that NSAID should be stopped, and probably patient may be introduced to simple analgesics like paracetamol and maybe topical NSAID with say warm massage of the limb, maybe using hot water or hot water bottles of the massaging the joints with those. So that can actually help. Having said that, using the combination of the two diuretics that she's using, HCT and the other one, amiloride, so that is also highly discouraging in older people, because we generally don't want to use diuretics for BP control in older people because of the increased risk of fall, increased risk of dehydration, and so many other problems. So it's better in this particular case to also stop the diuretics and consider using maybe a newer or better ACE or ARBs instead of the captopril, so that you can have more room of using higher doses of your drug to have an achievable BP control, and at the same time have the effects that it has in mortality benefit in heart failure. Then for the morphine that the patient was given, generally in older adults, we prefer using a very low dose at a start for most medications. So, for example, in this woman, maybe we may start with 2.5 milligrams of morphine. If that has no benefit in pain control, probably a 5 milligram dose should suffice. So, and that will address the need for her getting into toxicity. Thank you very much.
Yeah, thank you, Dr. Shamsuddin, for your contribution. Dr. Ekele, can you unshare the slide? Dr. Okocha? Dr. Okocha, can you? Dr. Okocha, can you hear me? Hello, Dr. Okocha, can you hear me? Okay, while we're waiting for Dr. Okocha, Dr. Yusuf said NSAIDs can be substituted for colchicine in this patient. It seems Dr. Okocha is no longer in the class. Dr. Hayford.
Yes, sir.
I'm here, sir. I'm finding
Okay.
difficult.
You're finding the what?
I was trying to share, but they're giving the right thing. So let me see. Share.
Okay, if you cannot share, maybe somebody will help you share. I think I shared your slides in the group.
Please, let someone help him share. This was what happened
Dr.
yesterday. I wasted our time.
Just
Dr. Atta, let someone help him share.
Let me highlight his slides. All right, Dr. Ekere, you might have to come help us again by sharing these slides for Dr. Okocha.
Okay, just a minute.
Okay. We can still contribute for the first question if you have any. You can type in the chat box.
Good morning, consultants. Good morning, all. I'll be answering practice question 5B, and the question goes like this. A 50-year-old man with typical myocardial infarction with blood pressure of 80/50 millimeters of mercury for about 2 hours despite inotropes. The ECR was normal. He had a CT angio done. Subsequently noticed cold extremities, bluish discoloration of his toes, and some skin rashes. Also noticed to have BP and tachycardia, low BP and tachycardia. 2 days after the procedure, his urea level went up to 10 millimoles per liter. Serum creatinine rose to 200 micromoles per liter. Urine microscopy showed granular cast. Renal ultrasound scan showed multiple hypoechoic areas. The questions. Number 1, what's your diagnosis? 2, what are the risk factors and causes of the diagnosis? 3, what tests will you do further to investigate this patient? 4, outline your principles of his management. 5, how will you prevent this condition? And 6, what do you give the patient when he is stable? Now, the diagnosis to the above question is acute tubular necrosis. And then the causes, majorly from 2 major causes here, he has contrast-induced nephropathy and cholesterol embolism. The risk factors in this patient include his hypotension, he has myocardial infarction, his contrast, contrast exposure, and then his male gender, which could dispose him to the contrast, to the cholesterol embolism. What tests will you do further to investigate this patient? Outside the above investigation that was done, the patient will benefit from full blood count, which we see, if in case of cholesterol embolism, we see high eosinophils, we see anemia for the AKI, definitely lipid profile, urinalysis, urine electrolytes, including urine sodium and urine urea, biopsy for the cholesterol embolism, if you want to really confirm that. However, if it's strictly ATN, it is not indicated. So yeah, ECG monitoring, because the patient has myocardial infarction, to monitor his progress of his disease, and then echocardiography. Outline your principle of his management. The patients need to be admitted in ICU. It must have to be a multidisciplinary approach, which includes a nephrologist, also a cardiology, and then anesthesia, to be precise. Patient benefit from supportive management, which is hydration. If patient is on anticoagulation, you stop, avoid vascular surgery, treat underlying risk factor, fluid, and then diet management. How will you prevent this condition? There are 2 major things you can do. You identify risk factors in patients, you hydrate prior to the procedure, and then you minimize contrast medium use. These are the 2 major ways one can prevent this condition from happening. Then what do you give to the patient when he's stable? Typically, you give the patient is having MI, and definitely you have to give statin and antiplatelets. Typically, you want to avoid anticoagulant because of the risk of further cholesterol embolism. Then the next in the slide is acute tubular necrosis. I'm going to follow this outline introduction down to my references. Next slide, sir. Introduction, the acute tubular necrosis is a kidney disorder involving damage to the tubular cells, resulting in an abrupt and sustained decline in GFR within minutes to days. Typically,
Dr. Kocha, Dr. Kocha, can you hear me?
Can you
hear me? Yeah, so please just go to, for this presentation, just go to the key points. I think we've solved this question before. So go to the key points that you want to highlight for us, so that you don't read all your slides.
So maybe you just died because I was not there when this question was solved. So
okay,
just tell me.
Probably go to the pathophysiology. Go to the pathophysiology, clinical features, and then principal management.
Thank you very much. So by way of etiopathogenesis, typically is of 2 major etiology: ischemia and toxins. For the ischemia, we are likely due to reduce or decline in renal blood flow, as you can see in this diagram here. The decreased renal blood flow can be due to hypotension, probably from shock, cardiovascular shock, maybe embolic shock, neurogenic shock, severe dehydration, septic infection, either of the following shock can result to hypotension, or probably via thromboembolic or cholesterol embolism, like we see in this patient, in a patient that might be predisposed, which may be due to atrial fibrillation, myocardial infarction, valvular heart disease, and the rest of them. It can also be due to thrombotic microangiopathy from either HES or TTP. All this may result to decrease in renal blood flow and then predispose the individual to renal acute tubular necrosis. Next slide, sir. Next slide, sir. Then for the nephrotoxic cause of etiology, because like I said, it has two major etiology, the ischemic etiology and the nephrotoxic or the toxic etiology. Then for the toxic etiology, toxic may be due to arise from or be result to direct injury due to any of the nephrotoxic substances such as medication, amyloglycoside, cisplatin, amphotericin B, lead poison, ethylene glycol, IV administration of iodine control, like you see in these are index patients. If due to rhabdomyolysis crush syndrome, which may result to myoglobinuria, therefore result to a pigment nephropathy, hemolysis, same, tumor syndrome, or probably from gout. All this may result to direct injury to the tubules. Next slide, sir. Like I said, is both either from the chemicals or from the toxins, all this may result to a direct cellular injury and definitely predispose the individual to tubular necrosis. And if care is not taken, may recover if it's a slight injury, or may progress to kidney failure, chronic kidney disease, or invariably may result to death of the renal parenchyma and causes what? May result to death. And you can see in the other slide here, which shows the morphology of a typical acute tubular necrosis. You can see this may be due to this nephron shows a typical ischemic tech, how it results. You can see this result to morph, a patchy pattern. And unlike the toxic type, which be due to the contract that the patient received, may result to, it tends to affect the proximal tubules commonly than any other part of the tube. The reason behind that is that the proximal tubules tend to be have high, ATP, have high oxygen demand, and also involved in high energy transport. So it's at risk of ischemia. So in toxic nephropathy, like in this patient, tends to affect more of the proximal tubules and therefore result to diffuse necrosis, as you can see in this patient. Next slide, sir. So typically, as part of the also the clinical presentation, typically one patient eventually result to the damage, the kidney, the nephrotoxic damage, or probably from the ischemic may result to necrotic proximal tubular cell will fall into with the toxin itself causing the damage. And if the tubular the tubules are affected and causes necrosis, this necrosis will result to what? So we tend to fall down to the tubules, and then result to the debris will tend to accumulate in the tubules and result to obstruction. And this obstruction will definitely cause what? A decrease in GFR. At the same time, there will be activation of the renin-angiotensin system, which will result to what? To increase in aldosterone release, and then result to increase in the absorption of sodium and water, definitely result to decline in increase urinary osmolarity, secretion of ADH, and as a result of that, result to increase in reabsorption of water and urea. This reabsorption of water and urea we tend to accumulate in the blood and definitely result to end organ damage such as pericarditis, encephalopathy, and definitely may result to hysteresis in terms of encephalopathy, and then azotemia if there's no clinical manifestation at this point in time. And definitely as a result of that, the increased reabsorption of sodium and water causes intravascular fluid expansion, therefore result to hypertension, and definitely overall may result to heart failure, which is cardiorenal syndrome. Eventually, if care is not taken, the intravascular fluid expansion will also result to pulmonary peripheral edema, therefore resulting to dyspnea, that the patient may present with. And also, there will be also decline in GFR may also result to progressive deterioration of the kidney function, and definitely result to tubular system remaining damaged after glomerular recovery. And this over time may tends to progress and result to anuria, or probably oliguria, from there anuria if care is not taken. After a very short period of time, from within 1 to 3 weeks, the cell begins to regenerate and probably result to the polyuric phase, in which we'll talk in the next slide. Next slide, sir. We have 3 major phases. Sometimes we could use 4 phases, depending on the books you read. For 3 phases of this ATN, we have the prodromal phase, or the initiation phase, we have the oliguric phase or the maintenance phase, and then lastly, we have the polyguric phase or the recovery phase. In the prodromal phase, typically what you see, because of the toxins, the nephrotoxins at this early stage, there'll be decrease in GFR, although not marked, but it will be progressive. And then because of there will be increase in toxic effects. If the patient is on nephrotoxic, if he's using nephrotoxic drugs, there'll be increase in toxic effects, and that might result to increase in free radicals. There'll be vasoconstriction. Eventually there'll be a free radicals release. That will further cause damage to the tubular cells. Then following that, there may be the oliguric phase. At this point in time, there will be further decline in GFR. There will be evidence of uremia, and this may last up to 1 to 3 weeks. Following that, because of the other part of the cell that is not damaged, that might cause some regeneration of the process, of the tubular process, which tends to regenerate back the tubes back to normal, and that may eventually result to the recovery phase. And if that does not occur, then the patient may tend to progress towards long-term CKD, or probably we result to more decline in BUN and creatinine. Next slide, sir. For the contrast with this nephropathy, typically is defined as a form of ATI. Is defined as a increase in or greater than 0.5 milligram per day of rise in serum creatinine, or 12% or more rise from baseline of serum creatinine within 2 to 5 days after or following the injection of or the exposure to contrast material. This contrast material, like we have in terms of, we have 3 major forms of contrast. It can be contrast, maybe positive and negative contrast. Like we are using ultrasound scan, typically those ones are more of a negative contrast. Or then for positive contrast, like the one that can be grouped into two. Majorly, we have the barium as in this contrast, and then we have the what do you call it? The iodine contrast. This is for typically I also have the gadolinium contrast for MRI. For the contracts like we use, typically will be iodine based and non-iodine based. For iodine based, maybe it will be ionic or non-ionic. And then for ionic based, can be also be osmolar, high osmolar or low osmolar, or probably intermediate in the range of osmolar products. But typically, if it is iodine based contract, these are the ones that typically cause more of the contrast-induced nephropathy. Other factors such as medication, hypertension, dehydration, or arterial embolism can precipitate AKI after exposure to contrast media. Next slide, sir. Now, for the cholesterol emboli, which is the second aspect of the etiology of this presentation, definitely is a syndrome that occurs when the cholesterol crystals and other contents of an atherosclerotic fluid embolizes. Now, when it embolizes, either for the person may have a background risk factor of atheromatosis disease, following an intervention, probably may occur spontaneously or may occur following a cardiovascular intervention, such as stents intervention and some other cardiovascular intervention, which may result to either cerebral embolization, may present with amaurosis vulgaris, TIA, stroke, but may also result to extremity, like what we've seen in our index patient, can cause purple toe syndrome, presenting with levator lenticularis and then necrosis of the toes with cyanosis. It can also present when it affects the viscerals, like the kidney, can cause multiple infarct in the kidney that might present with, on ultrasound scan, might have seen multiple infarcts, hypoechoic areas, lesions on your ultrasound scan, like in these patients. It can also occur spontaneously or induced by intervention, like I said. Next slide, sir. So for the investigation, like we said, we have urinalysis.
In your treatment, is there anything new you want to add?
Typically, the new thing is that prior to this time, we used to give N-acetylcysteine, but recent studies have shown that it is not used for the as a preventive measures to avoid contrast-induced nephropathy. That's one of the take-home message. And also, the other take-home message must to do with the fluid administration in this patient, fluid before, after. Usually, the fluid should be given, 4 to 6 hours before the procedure, and then following after the procedure, down to 24 hours. And definitely, the fluid of choice, according to the American guidelines, is normal saline. Unlike that, for the Chinese and the Asian, they tend to use the glucose and then with sodium bicarbonate, and as an addendum to the normal saline post contrast exposure. This is just an additional thing. Other things are more supportive management and the rest of them. Thank you very much.
Okay. All right, thank you very much, Dr. Kucha, for a wonderful presentation. Yes, we have seen this question before, we've treated this question before, but if we have any question, any contributions, we can go ahead. Dr. Esther, Dr. Kucha, listen, Dr. Esther is asking, why do you want to stop anticoagulants as part of your management from the STEM question? You mentioned you want to stop anticoagulants.
Okay. Thank you very much. The reason I said the patient is having myocardial infarction and probably he has a typical MI. If peradventure he has, because one of the predisposing factor to cholesterol embolism is anticoagulation. So if he has been on any, what I said was, but if it's on any, we stop, we avoid. If it's not on any, we don't need to. You may be silent about the whole thing. Hello?
Yeah, we can hear you, sorry. We can hear you.
Okay, so that's the reason why I said if peradventure is on any anticoagulation, we have to stop. Anticoagulation. Because if it's on anticoagulant, it tends to further dispatch them cholesterol plaques, crystals down to other organs, and that might result to further embolization of the crystals.
Okay. All right. Thank you for the explanation. Dr. Chika is saying, thanks for a beautiful presentation, but ATN is more of a histological diagnosis. So I think in a clinical setting, it's better to put the diagnosis as AKI instead of ATN.
Sorry, ATN is not a histological diagnosis. ATN is a clinical diagnosis. In fact, if you go to the literature, or any literature you want to quote, I can probably give me reference for you. Several literature is the clinical diagnosis. Never, ATN is never, it's never a histological diagnosis. Quote me anywhere. It is never, my brother.
All right. Dr. Chitu, good morning, sir. Good morning, sir.
Yeah, good morning, sir.
Okay, yeah, no, I'm talking of.
Hello?
Yes,
okay,
sir.
Morning, Dr. Atta. Yeah. The presenter, you've done well. But please, your last statement is going to spoil things. Yes, we can make a clinical assessment of acute tubular necrosis, right? Because there are things you can find in the urine, and of course, on examination of the patient, that would tell you, yes, this is acute tubular necrosis. Okay? But it's confirmed. The only way to truly say somebody has acute tubular necrosis is to actually biopsy, although it is not done commonly, okay? But if you are doing a study on acute tubular necrosis and you do not have histology, then that study will be thrown out. So that is why I would point out that yes, you do need histology to fully confirm that it is acute tubular necrosis, but you can make the diagnosis clinically. All right, but you can't confirm it until you do histology. So, and in an exam setting, please don't say things like "quote me anywhere" or anything of the sort. Please, try and be as humble as possible, even if you have your facts straight. Do you understand? So that you don't rub off somebody the wrong way. Do you understand?
Thank you very much. Thank you, sir.
Yes.
Thank you, sir.
Then just a few things I want to point out. When you're talking about contrast being given to patients for imaging, particularly the ones for radiological imaging, CT scan,
Yes.
X-rays, and all of that.
Yes.
Yes, we have high osmolar, which means that it has an osmolality that is way higher than the normal person's osmolality. And we have low osmolar. Does not mean it is lower than the normal person, the normal osmolality seen in people. Okay, what it means is that it's lower than the high one, but it's not exactly lower than the one that the osmolality of patients. Do you understand? Okay, it's just lower than the high one. Okay, then we have the isoosmolar. Now the isoosmolar is the one that is at par or at around the same level as normal osmolality in a person. Do you understand? So in that order, it's actually better in that order. Okay.
Yes, sir.
All right. So it gives you a better thing. Now, I also wanted to ask you one or two questions. One is that for a patient with acute tubular necrosis, right? You've already pointed out the proximal tubule is what is damaged, right?
Yes, sir.
Yes. And then for somebody to have acute kidney injury, the person must have a reduction in GFR. Do you agree?
Yes, sir.
Yes. So in acute tubular necrosis, how does the person develop a reduction in GFR?
Like I said in my pathophysiology,
let's assume it is a toxic nephropathy, meaning that you took a substance, all right? Not that there was low blood levels. If it was an ischemic one, then you know why it is so, right? It's straightforward.
Yeah.
But now,
Yes.
if it is toxic, how does the person develop a low GFR?
Yes, thank you very much, sir. Like I said, once there's a toxic, it affects the epithelial cells of the tubular the tubules. Now, once there's a injury, it causes a direct injury to the tubules. Now, once the direct injury, the epithelium becomes sloughed out or sloughed off. Sorry to say, when the epithelial line of the tubules are sloughed off, it tends to accumulate and then result to forms a debris obstructed pattern in the tubules. Now, those debris, when it forms a debris, it tends to cause an obstruction. And for that obstruction in the tubular cells tends to cause a decrease in GFR.
The obstruction, well, that is one of the ways, but the obstruction is not enough. There is something worse. And you mentioned it, but you mentioned it in passing. That is why I asked you the question, because you didn't give me the vibe that you knew that was what was causing the problem. As these cells die, of course, there's a lot of cytokine action and all of that. And that eventually causes vasoconstriction that reduces renal blood flow and ultimately causes GFR to drop. Okay?
Okay, sir. Thank you,
yes,
sir.
The obstruction may have a part, but the obstruction comes much later. But much earlier in the process, you have all that cytokine being released, and then, of course, the vasoconstriction and all of that. Okay? Now, the reason why that is important is my next question. Now, not everybody with acute tubular necrosis will start from oliguria to then eventually polyuric phase and recover. Some people may actually be non-oliguric, meaning that they are polyuric from the get-go. Okay? It depends on the extent of damage to the tubules. If it's really bad, of course, we do know that the way the blood supply to the kidney works is that the glomerulus gets supplied first before the tubules. So the tubules get leftovers. So when there is a problem with reduction in renal blood flow, the glomerulus will preserve itself at the expense of the tubules. Okay? So initially, when there's reduction in blood flow, the glomerulus will not filter because it doesn't have enough energy to do so, or doesn't have enough supply to do so. Okay, so there is oliguria. But during the recovery, or when the tubular damage is beginning to set in even more, okay, and you now restore blood supply. Okay, what happens is that the glomerulus will come back faster because it's the one that was not really starved. But because tubules have been damaged, okay, there is no reabsorption and there is no and all of that. So what happens is that the glomerulus is filtering with no reabsorption. So that's why the person would start to diurese, and hence we call it polyuric phase. But it is possible that the tubules are so damaged or so extensively damaged from the get-go that you do not see the oliguric phase. All you see is a non-oliguric AKI, which can occur in up to 50% of patients. That is actually that high. So a lot of people may go undetected because they are making good urine. And that's why we tend to rely more on creatinine levels to determine if the person is an AKI or not. Okay, so when describing those stages, if they ask you to do so, please always point out that, yes, even though you could go through this, some people may actually start from polyuria from the get-go.
Yes, sir. Example of individual are those that have, let's say, rhabdomyolysis can cause that non-oliguric phase. Even the contracts too that we give can also cause non-oliguric phase. These are with lower fractional excretion of sodium compared to the typical ATN. So typically they don't have those ones. You're right, sir. Thank you, sir.
Yeah. Yes, you're welcome. Yes. And then finally, please, for everyone to note, it's important to be able to differentiate an intrinsic damage from a pre-renal damage. Okay? From the urea and the creatinine levels, the ratio between them, and of course, what you get on urinalysis as well. You must be able to differentiate a pre-renal from an intrinsic kidney injury, particularly if the cause of the acute tubular necrosis is ischemic, because it will first start off as a pre-renal issue before it now becomes acute tubular necrosis, which is an intrinsic issue. Then the patterns will change. The pattern in the ratio of urea to creatinine will change. And of course, what you find on urinalysis will also change. I don't know, we don't have that much time this morning, so I may not go into all of that, okay? Unless we do. Dr. Atta, do we have the time?
Yes, okay. Okay, yeah, we can because the next question won't be able to take it because we just have 8 minutes more. So
okay, all right.
yes,
So to be able to differentiate that, please note that when there is a pre-renal thing, I'll just do it very briefly. When there's a pre-renal AKI or pre-renal injury, okay, it is presumed that the kidney is fine, and the problem is that the supply was not there for it to do its function. So the kidney is in preservation mode. It's trying to preserve itself. So in other words, it's preserving everything, okay? It is doing a lot of reabsorption of water, reabsorption of sodium, reabsorption of so many things, okay? And one of those things is reabsorbing as well is, believe it or not, urea, okay? So what you now have is that the urea to creatinine ratio is unusually distant. So you find a ratio that is greater than 100 to 1. Okay. Now, also, when you look at the urine of this patient, you'll find out that the urine has a very high osmolality. Hence, the specific gravity will be high because the body is in preservation mode. It's trying to absorb every bloody thing it can absorb. Okay. So particularly sodium. So you now find out that the sodium content of the urine is unusually low, okay? And of course, the fractional excretion of sodium will be unusually low because it's absorbing everything it can absorb. Now, by the time the kidney starts getting injured directly by, of course, the ischemia, okay? You now start seeing a pattern in which the body can no longer preserve itself because the tubules are getting damaged. So what is happening here is that because the tubules are damaged, okay, the normal secretion of creatinine that was adding to the distance in the pre-renal case, that is why the distance is that huge. A lot of reabsorption of urea and a lot of secretion of creatinine. So that widens the distance. So that's why it's high at 100 to 1 pre-renally. But when there's an intrinsic damage, you cannot reabsorb the urea like that. So urea is being lost. And then, of course, the creatinine is not also being secreted as much as it was. So the ratio shortens. In other words, they come closer together in quantity. So you now have values of less than 40. So the ratio is less than 40 to 1. Okay, when there is an intrinsic damage, because you can't reabsorb and you can't reabsorb urea, you can't secrete creatinine, right? Now, as you look at the urine itself, because it can no longer preserve, what now happens is that your person starts to lose sodium because there's no longer any reabsorption. And we do know that a lot of sodium is reabsorbed from the proximal convoluted tubules. Okay. Added to that, all the water is not reabsorbed because sodium is not being reabsorbed. So the specific gravity of urine drops. Okay. So you start seeing things like 1.010. Okay. So you start seeing values closer to that of plasma. Okay. Then you would also expect that the fractional excretion of sodium will also increase because you're not reabsorbing the sodium. And of course, osmolality will reduce because you're not reabsorbing water. So the urine is no longer concentrated. All right. So basically that's how you differentiate both of them. And it's one of the reasons why you can actually make a diagnosis of acute tubular necrosis clinically using these values. Yes. All right. I think that's just it. I just wanted to Notice that.
All right. Thank you very much, sir, for wonderful contributions, sir, and always. Okay. Okay. Do we have any questions or clarifications? Because our time is fast spent. So, Hayford and Joy will present tomorrow because I don't think we have enough time to take a third presentation this morning. So, I'll hand over to Dr. Christabel in the absence of any question or contributions.
Thank you, Dr. Wata. Dr. Wata, I hope I can be heard clearly.
You can be heard now.
Okay, thank you. So,
Hello. Dr. Christopher.
Yes, you want to say something?
Can you hear me?
Yes.
No, I just wanted to add that our presenter, just like Dr. Shitu said, please, some humility. He asked you a question, and your first answer was, as I said before. Please don't start like that to answer questions. You know? Even if you didn't hear what you said before, it's still okay to repeat it. But when you're saying, as I said before, it sounds as if you are like, didn't you hear when I said it before? So please, that's not a good way to answer questions. Okay. Then just I also wanted to chip in that. Hello, can you still hear me?
Yeah, we can
Yes,
hear
we can hear you.
Yeah, this particular question, even till now, I'm not completely sure if the answer should be acute tubular necrosis or acute kidney injury. Okay. Why acute tubular necrosis is high on the list is because they actually mentioned the granular cast. That's pathognomonic for acute tubular necrosis. And if someone makes that diagnosis, the person cannot be wrong. However, I don't know if that's the answer they want. Maybe people that went for this exam would contribute here. Because the truth is, they may actually want you to say acute kidney injury. All right?
But
So
Dr.
then,
Dr.
yes, sir.
I want to say, why not say both? Why not say it's
Okay, yeah,
acute kidney
yeah, I think
injury
that's okay.
secondary to
Yes,
acute necrosis?
exactly. But that's the best answer. I think that's the best
Covered.
answer. Yeah, so you are covered. Okay, so I think yes, you are very correct. Yes, acute kidney injury secondary to acute tubular necrosis should be the perfect answer for that question. Yes. Okay, so I think that's what the only other thing that was a bit hazy. But now that Chief Shitu has clarified, I think I don't have much to say again. Well done.
Thank you, Dr. Remigius. Thank you so much. I must commend